Hi, everybody. So, just to set a little bit of a scene, we're going to hear today from two teams who have done outpatient group clinics, and Wales is way ahead of the game at the moment in relation to introducing the group clinic model into outpatient settings. I'm just going to start it off by just giving a little bit of context from the recently uh, issued Darzi report, which is focused on England, but I'm sure this really resonates with those of you from Wales as well. So it's a really interesting report if you haven't read it yet, and it really gives a sort of state of the NHS overview of how we have compared really importantly with other countries. So, just some quick headlines from that is that the NHS delayed, cancelled, or postponed far more routine care during the pandemic than any other comparable health system in the world. So the what we're feeling at the moment in terms of the pressure because of the our waiting list is partly down to what happened during the COVID period. And as a result of that, and as a result of lots of people rocking up at A&E and lots of people staying in hospital beds longer than they need to, the productivity in our acute sector has really fallen off over the last few years. So in England in June 2024, the total waiting list was 7.6 million people, and more than 300,000 of those have been waiting a year. And many, 1.75 million have been waiting between 6 and 12 months. So we can see that we have got a huge issue with waiting. And the longer that people wait for an operation, the more likely it is that they will decondition and that the outcomes of that operation will be less optimal than it would. And that's one of the reasons why it's so exciting to hear from Ben and Catherine today, who are going to share what has been happening in their health board around supporting this. The other thing that we need to remember is that as a result of the pressures that people are feeling, a lot of staff in the NHS are feeling a little bit disengaged at the moment. We have in the NHS in England the highest levels of staff sickness that we've had ever. And we're losing an average of one working month per annum for many doctors and nurses. And also, there are very low levels of discretionary effort. The reason I mention this is because one of the things that we found in the evaluation of the Welsh group clinic programme is that it had a really significant impact on staff well-being and specifically increased the discretionary effort amongst staff because they felt really empowered by being able to introduce the group clinic model. The other thing that is picks up on is that the patient voice is not strong enough, and the group clinic model can help with that because it puts patients back in the driving seat within their own clinic appointments, and they in effect co-produce the agenda for the clinical appointment with the clinicians in the group clinic. And that is really powerful. So think about this group clinic model as something that can help you to address those practical issues around waiting, but that will also help to re-engage and make your staff feel really joyful about their clinical work and put patients' voice at the center of the consultations and clinics that you run. Okay. So I just wanted to quickly mention to you, because many of you may not necessarily be from obs and gynae or working in the sort of physiotherapy area, that this kind of work, this kind of model can work in lots of different disciplines. So we've got examples from dermatology, we've got examples from oncology, we've got examples from rheumatoid arthritis management and pain management, diabetes. So if you're interested in any of these, we have case studies on our website. Do go and have a look and pick up on those. Okay, so let's move forward and let me introduce the first team. That's Ben and Catherine. And we look forward to hearing your amazing story around the work you've been doing in your health boards. Over to you, guys.
Thank you. So my name's Ben Matthews, and I'm the clinical lead physiotherapist in what is now the Prehabilitation and Optimisation Service in Hywel Dda University Health Board. And it was the Orthopaedic Prehabilitation Service. Next slide, please. So just to introduce you to the clinicians in the team. So Catherine Davis is on the call today. So she's the clinical lead occupational therapist in the service. We also have 2 dietitians that make a whole-time equivalent. We have 2 therapy assistant kind of practitioners, and we also have part-time admin staff. Next slide, Sid, please. So just to give you a bit of background, we started its development in September 21 and started patient contact in January 22. The main reason for its development was due to the pandemic's impact on planned waiting lists for total hip and total knee replacements. It was or has been funded by the Welsh Government, and we provide a holistic MDT approach to assessment and treatment. Next slide, please. So to assess these patients, we developed an MDT assessment template. The assessment is done by one of us in the team, preferably virtually, or we can do it over the phone. So prior to each assessment, an electronic PROM is sent for the patient to complete, which entails basic information about the patient, their Oxford knee or hip scores, and also an EQ5DL score. We also use this PROM at the end of our intervention in order to help us kind of assess our intervention. Next slide, please. So from our assessment, we have 3 options or tiers in how we can support patients. So we have tier 1, which is our 8-week prehabilitation care plan that we developed and is on PKB, which is a digital personal held health record. Tier 2 then is why we're here today, is our virtual group prehab supported by technology enabled care. And tier 3 then, so that was for that's our virtual one-to-one input, and that's for patients with more complex care needs who are not suitable for group consultations. Next slide, please. So why virtual, why group? So Hywel Dda Health Board is committed to promoting digital inclusion and improving the digital skills of patients. And as we know, that can increase, an increase in digital engagement can offer better outcomes such as improving health and well-being, decreasing loneliness, social isolation, offering better access to opportunities, jobs, education, and also services. As you can see, from this map of Hywel Dda, we cover a large geographical area with a lot of patients in rural communities. Some patients, due to their condition or conditions, have difficulty accessing face-to-face appointments and can also be housebound. There were over 4,000 patients waiting for hip and knee replacement surgery in our health board, and we are a small team, so we identified that by adopting a virtual model, it allowed us to provide the same standard of care no matter where they lived in the health board. We also believe that these patients would have similar presentations while waiting for surgery, and by grouping these patients we would be able to provide the intervention to more people, and the patients would feel comfort and support from others in a similar situation to them. We were also post-COVID, where groups of people hadn't met for a long time, and there was still some concerns with some people regarding meeting face to face. Therefore, this option would suit them, but also support the notion of interacting within a group setting. Next slide, please. So prior to starting our virtual group consultations, there were a number of things we needed to put in place. We looked at what training the staff required, as we were all new to working with virtual platforms. We as clinicians attended the Welsh National Symposium on video group clinics, and then I think a short time after that, everyone attended the video group clinic training, which was provided by Redmore Health. This helped us put processes in place to ensure patients had a full understanding of virtual group consultations, and that confidentiality clauses were adhered to. We as a team agreed an escalation policy if there was any conflict within the group, as we thought that may occur. And in the first group session, we made sure we set some ground rules, but we also attach the patient agreement to each invite, and also remembering the need to blind copy other patients when inviting them in a group email, which was important, so that others don't see each other's email addresses. Partnership with Delta Wellbeing was agreed to support digital inclusion for these patients, and we decided on ideally 2 staff members being present in the virtual group consultations for safety purposes. We developed the content of the program, and this has developed over time. Next slide, please. It consists of a 12-week program. So we chose 12-week as it fits with behavior change models. We did one session of roughly an hour long each week. Again, we chose once a week and chose 1 hour only because we thought that would be something that wouldn't ask too much of the patient and something they could commit to over the 12 weeks. We do it either over Attend Anywhere or Microsoft Teams, but have shifted more towards Teams recently. All patients within our 12-week program get a digital tech bundle that includes blood pressure, heart rate monitor, oxygen saturation monitor, and a weigh-in scale. And some patients have access or can have access to a device or an iPad, so they can be included in the group program. These patients use these monitoring devices twice a week, and we also get the patients to answer 5 questions, which is related to the EQ5DL outcome measure about how they're managing, in order that we can assess how they are, and if we need to intervene or appropriately, we can escalate. The virtual sessions consist of an education and discussion element, and then a facilitated exercise session. Over the first 6 months, we trialed 4 patients, we trialed 8 patients to work out what the ideal number for a group in this setting is. Okay, next slide. So between when we started and I think this time last year, we assessed 450 patients. 126 patients have been through our 12-week program. Others had one-to-one intervention, registered on PKB, given advice, signposted to other appropriate or relevant services. 34 of the patients who, out of the 126 who never used technology before, were provided with equipment, tablets, and successfully supported to start using digital platforms and accessed the virtual group consultations. Next slide, please. So just more on the outcomes. We had a high completion rate with less than 9% dropout rate, and of that 9%, some of those patients had a date for surgery within the 12 weeks, so they had to leave the program because they were having surgery. 64% of patients lost weight, 17% of patients lost more than 4 kilograms. There were improved Oxford hip and knee scores, increased level of physical activity with these patients when we redid the PROM at the end of our intervention, and we had improved health management, mainly in terms of blood pressure throughout the program. We have also seen that there has been a decreased length of stay in some of the patients that have been through our group program, but more work is needed to kind of evaluate that. But we are getting feedback from staff on the ward that these patients are better prepared for surgery. Next slide, please. So here is some feedback we've had from patients. So at the end of the 12-week program, we do a feedback and a kind of discharge summary session with them, a one-to-one session, where they would have completed another PROM, they would have completed a PREM, and then we also get some feedback from the patient. We've had a lot of positive feedback from improving the patient's health and supporting them while they're waiting for surgery, introducing them to virtual technology, improving their confidence or increasing their confidence kind of digitally. And patients have enjoyed doing it from the comfort of their own home and learning from other patients then in the same situation as them. Next slide, please. So here's some of the staff feedback. I think this, this is a knock-on effect from the patient kind of outcomes. We've been able to kind of support patients that would never have been able to access kind of group consultations. I think it gives us, as you can see from one of the quotes there, it makes your job feel worthwhile when you're kind of seeing and getting this feedback. And so I think it's been a positive on all parts. And next slide, please. Nearly finished. So some of the learnings. So things we learned from developing and implementing the service, and specifically with the virtual group consultations, was that adopting a virtual first service model helped. So virtual was our default setting. Partnership with Delta Wellbeing was needed to successfully implement digital solutions with some patients. We were fortunate the members of our team bought into the virtual concept, and this was key to the patient buying in and engaging. Age was definitely not a barrier to virtual group clinics, consultations. We had patients from early 50s to 92 years of age involved. It also, as we went on, it also justified our decision for using virtual group consultation, as it was the case that face-to-face appointments would have led to exclusion, not inclusion for these patients. So like we predicted, a lot of these patients were unable to travel. Some of the time they were indeed housebound, and they would have been reliant on other people to travel. And at the beginning, we were almost presenting a PowerPoint presentation to these patients for the advice and education part of the session. We soon kind of came to realize that it wasn't the best way to engage patients, and we took on a more of a facilitator role. So we were aiming to kind of promote patient engagement discussions, and this led to kind of patients sharing ideas on how they manage and also their experiences, which other people in the group learned from, and that that helped them a lot. As facilitators, our role is to ensure each group member has the opportunity to participate in discussion, so everyone gets the most out of the session. And like we said earlier, we did trial different numbers in groups. We learned that 8 was too many to get everyone involved in the discussions, and some felt overwhelmed with the amount of patients that were in. With 8 patients, it became less personal, and we also weren't able to clearly see everyone on screen, which is important, particularly for the exercise element of our program. Four, when we did four in a group, it worked well. And in particular, we had engagement from possibly what would have been the quieter members of the group. However, we do understand to continue to be more efficient and effective, a larger patient group was needed. We therefore decided on 6 being our ideal number. And this is something that we continue to use today. Next slide, please. Last one. So what's happening now and what's next? So we did secure permanent funding from Welsh Government to continue with prehab, but this also now includes optimization, which we are now targeting patients earlier in the pathway. We're expanding the offer of prehab and optimization to other surgeries within the health board. It was in our virtual model, which has proved successful and was listed in the 3 policies as good practice. And as a team, we are working with a quality and improvement team in the health board to develop and deliver a 12-week virtual group prehabilitation program for patients waiting for their gynecological surgeries. So that's what's happening next. Next slide. Thank you. And any questions, if you just put in the chat, that'll be great. Thank you.
Thanks very much, Ben. Can I just, I think just before we move on to Nadia, a couple of people have asked, can you just explain a little bit more about who helped with the technology? I see that Catherine's popped a little message into the chat about that. Do you want to just say something about how you connected with Delta Wellbeing? Are they part of your local kind of community support for digital inclusion, or did you commission them, or how did that work?
Kath, do you want to take us?
Yeah, so we partnership with Delta Wellbeing, who are part of our local council in Carmarthenshire. And they loan out the equipment. So they take out all the health monitoring equipment. They explain to patients how to use them. Then these devices were then linked to a Tunstall platform, which I've just sort of explained in the chat. So this was Bluetoothed. So all their readings were coming through to us through Tunstall, where we were able to monitor their readings then on a weekly basis. And I think somebody's just asked in the chat, I was answering about the loan of the equipment. So they'd have the equipment for 12 weeks. Delta would then collect the equipment. But often what we found was people would go and buy their own sort of blood pressure monitor, then their own weighing scales to continue monitoring their health, because they learned sort of how important it was.
Yeah, that's really interesting. And can I just check? So Delta, they were the kind of partner around the sort of, if you like, the virtual health, collecting in that data around the BP, etc. But how about getting people online? You said that, so you described, Ben, how, even some people who really struggled a little bit with their technology at the start, they fairly quickly got used to it and were able to access it. Did Delta have any role in that or not?
Yes. So Delta would basically teach somebody how to access us online. So right. They would provide face-to-face visits until that person was confident to access a group. And then us as a team then would practice even more until they were confident to join a group. So yeah, Delta have been key really in sort of providing this service for a lot of our patients.
Brilliant. Thank you for clarifying that. And I just want to say on this that I know that in an outpatient setting, often the video group model works better because estate is very limited for face-to-face. And I think what's really amazing about how the story you've told us, apart from obviously the really positive impact it's had for patients and how it's going to help them to stay well up until their surgery, is the actually you've kind of, against perhaps what people might think intuitively, the video group clinic model has actually been more inclusive because these patients struggle to get to hospital. And in Wales in particular, of course, you've also often got very long distances that people are having to travel as well. So, I mean, it's a great story, not only around helping to support better outcomes, but also making services more inclusive. Rebecca has asked a question about how this could be used for pelvic urogyne, pelvic floor physio. I'm going to ask you to reflect on that. That issue, I don't know if it's the same in Wales, but in England, there are huge issues around access to urogyne services, and it would be really interesting to hear from you guys what your reflections would be on that. And I think that might also be very relevant to Nadia's thinking about future ways of using group clinics. So I'd like to take a little quick discussion about that after we've heard from Nadia, if that's possible. But I know, Nadia, you've also got to leave, so let's move on to your presentation. And guys, if you've got any other thoughts on how you might use group clinics in an outpatient setting, do pop them into the chat.
Okay, good afternoon, everybody. Ben and Catherine, that's a good presentation to follow, as I only got mine ready last night. So first of all, before I start, I'd really like to say thank you to ELC, who've really supported us in our journey of getting our video group clinics up and running within our health board. And as I put my slides together yesterday, I'm really sorry, but this would not have been possible without the amazing team that are behind these clinics. And there's about 12 people in our team who all went ahead with the training. So we have 2 nurses supported by our nurse lead. Our directorate have been really forward thinking in supporting us with getting the clinics up and running. And we have 4 amazing admin staff who are working really tirelessly behind the scenes to get our video group clinics running smoothly and effectively. And before I move on to the challenges of setting them up and why we went ahead, within Cwmtaf Morgannwg University Health Board, I believe that we're quite a forward-thinking health board, and we have an amazing wellness improvement service, which is led by a colleague of mine who was quite instrumental in bringing video group clinics into our health board. So she really kind of was the springboard for me to think about, okay, how can we bring video group clinics into menopause care? Next slide, please. So the challenge that we face is that we know 51% of our population are going to experience menopause, and certainly within Cwmtaf, 80% of our staff are female, and there have been huge delays with care, with treatment, and untreated menopause can lead to depression, suicide, time off work, or even resignation. And the challenges that we face is there are huge strains on secondary care. So just in case I didn't mention, this is a menopause clinic within secondary care looking after complex patients. So when Helena put that triangle of the levels of care, this is probably more simple to complex. And so we have a huge strain on secondary care. Our services are busting at the seams. We've got this escalated demand, and complaints are quite frequent, and on top of all of that, we also have a tired work staff and a burnt out work staff. And so our focus and our thoughts behind introducing video group clinics was really as an aspiration to introduce maybe an innovative option to increase capacity, but as well as accessibility to women who may find it challenging to come into secondary care, and maybe as well selfishly that we could look at a different way of working that may increase job satisfaction and hopefully help with tackling burnout. Next slide, please. So looking at different models of care, we wanted to aim for something that was going to give us good outcomes, high satisfaction with our staff and our patients, that would provide good education, and let's be honest, also cost effective. Next slide, please. So when looking at group consultations, what's the evidence behind, if you don't mind, I'll summarise it to VGCs. Well, we know that VGCs can increase capacity by about 400%. And they have been around for quite a long time, and they actually really started in gynecology, and some of the models are from the US, where what they called shared medical appointments in those days were introduced for gynecology cancer patients, and the feedback was that those who attended the SMAs were quite highly satisfied, and a pilot intervention which was published, I believe, in the Lancet, looking at menopause VGCs in primary care, had showed improved physical symptoms, and patients and families would recommend this form of clinics. And for participants, well, those who participate in providing VGCs or shared medical appointments find that there's good multidisciplinary learning. To be able to provide a VGC, you have to be good at what you do. You have to be certainly upskilled. You've got to be able to think quickly. So you're we tend to look at patients in advance to be able to make sure that if there's anything that's going to crop up, for example, certain conditions around menopause, we'll read up on those before our clinics actually take place. And there's good internal feedback throughout the clinic. And VGCs have been shown to improve staff morale, burnout, and job satisfaction. So we started our journey in June 2023. We signed up with ELC, and we put together a team of who was going to undertake the training. And as I mentioned, it was the 12 of us, 2 doctors, 2 nurses, our directorate team, and our admin and secretaries all were part of the training process. And we, as advised and as following the pathway by ELC, we set a date of when we wanted to get the clinics up and running, and then we worked backwards, and we also did dry runs with our staff. As I mentioned, 80% of our staff are female, and we serve the community and our staff. So actually there was quite a good number of staff who were quite happy to be invited to VGCs as dry runs. Next slide, please. So once we'd had our dry runs up and running, this was our group clinic design. So our recruitment was patients who are currently on our menopause service waiting list. And to put it in perspective, in June last year, I was appointed as a menopause service lead. Our waiting times it was about 78 weeks. Within that time frame, we very quickly, as Ben mentioned, we had to kind of introduce more of a virtual model. So we moved many patients onto telephone clinics in preparation for the VGCs. The number of patients we set as a maximum of 6. Those who run menopause clinic know that women need time, so anything more than 6 would probably be not satisfactory. In order to gain information before running a clinic, we set up on Microsoft Forms a digital green climacteric scale, which is a validated questionnaire. And for pre-clinic preparation, our facilitator, who is one of our nurses with an interest in menopause care, would put all the patient's details into an Excel sheet, summarize the green climacteric scale findings, and add them to our symptom board. We would then summarize the referral letter from the GP into a running chart. So we currently have a running chart of all our patients who've been part of the video group clinics, and the length of our clinics were 90 minutes. Next slide, please. So the flow, we start off with 15 minutes of check-in, the confidentiality, consent, privacy, location, and we've assigned clinician time of 60 minutes, and that would allow me to have, if there are 6 participants, we would time about 10 minutes of one-to-one time within the group. Our groups are also currently attended by our menopause nurse specialist, who was appointed in January this year. So it's been a great opportunity to kind of accelerate her education and training in menopause care. And between ourselves, I will kind of make notes as I'm doing the clinic, the facilitator and the nurse specialist. And then we have 15 minutes of wrap-up time at the end. And we always ask the question within the clinic at the end of what went well and what could be done better. Post-clinic, we have a 30-minute catch-up of where we go through everything as a team. So myself, Vicky, Helen, if we've got any kind of trainees or medical students who are actually sitting with us throughout the consultations, we'll have a discussion of, what went well here, what could we have done better, and then what we're currently doing at this moment in time, and you probably can appreciate, we are seeing very complex patients who have quite complex needs. Our menopause nurse specialist will then follow up within that half an hour with each participant, just to make sure that they're clear on what the plan was, to maybe finalise the prescriptions that we've recommended at the time of the consultation, and to maybe do some investigations or request investigations. At the moment, our VGCs are new patients only. So all patients are then offered a one-to-one telephone catch-up with either myself or any of the clinicians or a nurse, our menopause nurse specialist. We're hoping that we've run now 12 video group clinics, and we've seen probably about 66 patients in those 12 clinics, and we're hoping that the next phase will be to have video group clinics for follow-up patients. Next slide, please. So this is what we have on our results board. We have their age, what's their total green climacteric scale score, and that's usually a really good starting point, because obviously the higher the score, the more symptoms that patients have. We then divide it into the psychological symptoms, which would be anxiety, depression, physical symptoms, vasomotor, their sexual symptoms, and genitourinary syndrome of menopause. We've put together 3 questions which kind of covers that, and if they're currently on HRT or not. Next slide, please. So what we have found, if we look at efficiency, if I were to run my standard secondary care menopause clinic, we used to give 40 minutes for a new consultation per patient. We have now, post-COVID, we've kind of dropped that down to 30. So even if I were to see 6 new patients in my clinic, and my clinic is 3.5 hours, I'd only be able to see 6 new patients really, and maybe 1 follow-up. What we're doing at the moment, we've got 6 new patients in 1.5 hours, and we also add on 4 telephone follow-up. So we have 10 patients per clinic. And I believe that we're kind of in our infancy with our VGC, so we haven't really pushed the boundaries yet. We have 1 VGC and the rest of the clinic is follow-ups. We're 6 months down the line. We are possibly going to be looking to probably have 2 VGCs per clinic, which would allow us to see 12 new patients, and then we could do telephone follow-ups in a different kind of setting. Our current main access gain to is training really. By having the video group clinics, we found that our menopause nurse specialist is really accelerating in her knowledge. We are kind of having to improve our own education. Also, we have trainees, we have medical students who sit in, and they are finding huge benefit. And our VGC clinic is the foundation for what we're developing which is why I will be connecting with Ben and Catherine, is our VGC Lifestyle Improvement Service, which is currently in development, which is going to be called MALI, so the Menopause and Lifestyle Improvement Service. And so our menopause VGCs are going to springboard into the group being invited to a lifestyle improvement package of care, which will probably be over 6 to 8 weeks. Next slide, please. So from a clinical impact perspective, well, being within a group, the women themselves get a better understanding of menopause. The groups, we currently divide them into under 45s and over 45s, as women who are going through premature ovarian insufficiency or early menopause may have slightly different needs than women who are going through natural menopause over the age of 45. We don't believe that there's been any compromise on clinical care. The women are kind of being looked after and managed as we would in any kind of menopause clinic. If there's anything abnormal, this is picked up and followed up appropriately. We find that the women themselves feel so much better after being to the clinic. They've expressed relief, they're happy, and they feel that they've had a better understanding of their symptoms, which is having a positive impact really on their mental and emotional well-being. And discussing lifestyle changes as a lifestyle medicine practitioner, that's what we do routinely, which we believe will impact not only on their menopause care, but really on all areas of health and hopefully their longevity. Next slide, please. From a psychosocial impact, we've had very positive feedback from disabled and mental health patients who find that they have big anxiety coming into the hospital. Initially, we were thinking, well, will patients actually be open to the idea of coming to an appointment, which is an hour and a half? And it was really interesting from our initial dry run clinics that one patient said, well, if I had to come to the hospital, it would take me, I'd have to get a emergency taxi at 7:30 in the morning. I'd be hanging around till my appointment. I'd be waiting there in the clinic, and I wouldn't get home till about 11, 12 o'clock. So this particular group of patients have found the clinics really invaluable. Lots of patients report back that they don't feel as alone, and they learn from listening to each other. And it's also quite interesting how some women express this attitude of gratitude, where they actually feel that maybe what they're going through is not as bad when they hear what other women are going through in the group. And then it's quite lovely. We'll see in the chat function how women share some of their effective treatments. They're actually learning through questions. There's a sense of relief and almost this sense of acceptance of the menopause, and they feel quite empowered on this next chapter within their life. As yet, we haven't seen any friendships that have come out of our VGCs, as our patients are only new patients. They're not coming up to a follow-up appointment together. So hopefully that's what we'll find with our next aspiration projects with VGCs. Next slide, please. So from our whole experience, I believe that our patients' positive feedback is a real testimonial to the power and the wonder, I feel, of the VGC. And this there's a positive ripple that will go on into all areas of the biosocial cultural model of menopause. But it's not all sailing. As with any new service, it has been a little bit challenging. It's definitely been hard work. There's a lot of investment that has to go in advance. It can't be something that happens overnight. It takes a lot of time. And I think also one of the challenges is not only the staff having an open mind to this new way of working, but also trying to get the patients to accept this this new way of sharing their experience with other people being there in the room. And I do believe that the main drivers of the success is a really united, passionate and dedicated team. We've had real good support from our management team, and we tend to communicate with each other. We have at least one monthly admin meeting where we go through all of these, and also we're very grateful to ELC for giving us that foundation and taking this vision forward. Next slide, please. So I'm just mindful of time. There's a few of our patients' feedback, which you can read on the slides if they're shared, or if you go back to the recording. One in the middle, which I thought was quite endearing, was being able to listen to what everyone else is going through and where I am having similar issues, hearing more about different options. I did think this was going to be just like the Cardiff Council Menopause Support Group, but it's been so much more than that. Next slide, please. And that's a little bit of feedback from Vicky, who's our nurse facilitator, and Vicky always feels that the VGCs have transformed the way that we're offering care. Next slide, please. And that's my final slide, just giving you a bit of a insight into one of our dry run participants' feedback, who was a member of staff. Thank you very much for listening.
Thank you so much, Nadia. It actually makes me quite emotional reading some of that feedback. I have to say, some days it's hard doing, driving forward innovation like group clinics. And, when you hear stories like the ones that you guys have shared today, it just makes it all feel worthwhile. So it's amazing. Thank you so much.